everyone, and welcome to today's webinar, Lower Respiratory Tract Infections in Outpatients, Bacterial Causes, or Do Viruses Also Matter? I am Jelena Feenstra, and I will be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Thermo Fisher Scientific, and to learn more, visit thermofisher.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into Ask a Question box and click Send. We will answer as many questions as we have time for at the end of the presentation. And also feel free to submit any technical issues here as well if you have any trouble seeing or hearing the presentations. I would like to welcome our speakers today. The first speaker, Professor Dr. Ieven. She is an emeritus professor at the Faculty of Medicine in Antwerp, Belgium. And our second speaker will be Israel Figueroa, Senior Product Manager at Thermo Fisher Scientific. For a complete biography of our speakers today, you can click their name in the presenter's window at the top right of your screen. Professor Ieven will be our first speaker today, and you may begin your presentation. Thank you.
Good morning, everyone, or good afternoon, wherever you are in the world. Today we're going to talk about lower respiratory tract infections in the community in outpatients. How important are bacteria and viruses, and what have we learned so far? These are my disclosures. I'm not going to read them to you, so let's just skip them and let's start right away. Why is it important to study the etiology of lower respiratory tract infections? Well, as you know, acute respiratory illness are among the most common reasons for consulting a GP. And these GPs will very often prescribe antibiotics because they think or they assume that pneumococcus or Haemophilus influenzae or Moraxella catarrhalis may be the cause of this lower respiratory tract infections. So we know that the majority of antibiotics are indeed prescribed in primary care. And that results, of course, in antibiotic resistance. It's a major public health problem. And that has been shown already in 2005 by my colleague Herman Goossens. And we see this in this slide, where the prescription of penicillin is registered, and also the antibiotic resistance. So what we can see here is a higher antibiotic resistance of pneumococci for penicillin, mainly in southern European countries such as Spain, Portugal, but also France, compared to very low resistance rates in these countries where there are low antibiotic prescriptions, such as the Netherlands, Denmark, Sweden, and so forth. So it is very important, in order to reduce this antibiotic overprescription, to also concentrate on the real etiologies of LRTI. As we know, when a GP sees a patient presenting with LRTI, they mainly have to rely on signs and symptoms: a running nose, coughing, wheezing, with or without temperature, etc. And that is very understandable, because it is not practical, if even not feasible, to take samples from all these patients, because it takes time to take the sample. It's expensive. It's not only expensive to take these samples, but also to analyze these samples. And it takes a while before the result of these samples is sent back to the GP. So he or she cannot really take into account the result of these analyses to manage the patient's symptoms. So as a consequence, little is known on the etiology of lower respiratory tract infections. Okay, so we all know about the SARS-CoV-2 virus since the pandemic, the COVID pandemic, but SARS-CoV-2 virus was certainly not the first coronavirus. Already in 2003, Christian Drosten described a human coronavirus causing a severe acute respiratory syndrome, thereby the name SARS. Afterwards, in 2005, a few other coronaviruses were described, such as the NL63 and also the Hong Kong coronaviruses, causing mild respiratory symptoms, much milder than the SARS-CoV-2 virus. And we also know about the MERS coronavirus, described in 2012, the MERS coronavirus, which is a zoonotic infection mainly seen in Saudi Arabia. What about rhinoviruses? We know rhinoviruses since many decades, but every now and then a new variant of rhinoviruses is being described, such as the rhinovirus C in 2007. And then, of course, there are the many new variants of influenza virus, and I just mentioned a few of these here, such as influenza H5N1 in 2003, influenza H1N1 in 2009, and the H7N9 variant in 2013. And there are many, many others described over the years. So the spectrum of viral targets increases dramatically. And as a consequence, molecular diagnostics are also updated constantly. In most of the molecular diagnostic tests or panels, the most important viruses are included, such as the influenza viruses A and B, the para-influenza viruses, and RSV, but recently, of course, also SARS-CoV-2. But more and more, many multiplex panels also include many other respiratory viruses, which are considered more and more also as important. Then we will show that later on in this presentation. For example, the rhinoviruses, very important, but also the seasonal coronaviruses, human metapneumovirus, and also some bacteria, such as mainly the atypical bacteria, Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella pneumophila, and Bordetella pertussis. So there is now a multitude of commercially available tests, either targeting just one target, for example, this TaqPath Mycoplasma pneumoniae PCR kit, detecting just Mycoplasma pneumoniae, or some very well-known tests from Cepheid, the flu expert targeting influenza A and subtyping of influenza A, or the RSV-A and RSV-B targets in this test of Cepheid. But there are also mainly multiplex panels more and more becoming available, such as the Luminix panel, detecting only a number of viruses, but a large number of viruses, 19 in this case, or also the RespiFinder, not only targeting a large number of respiratory viruses, but also a number of these atypical bacteria, such as Mycoplasma, Legionella, Bordetella, as mentioned earlier. But there are many more. Now, the test you're going to use very much depends on the objective you have. If you just want to diagnose an influenza infection or an RSV infection during the winter peak, you do not need to use such a comprehensive panel detecting all these viruses. You can just take a panel or a test targeting influenza, RSV, or a combination of both. If you want to do an epidemiological study and you want to know what viruses, which viruses are circulating in a certain patient population or in a certain geographical area, then you rather go to a multiplex panel, of course. Now, in any case, before deciding on what kind of test or panel you're going to use, it's very important to validate this test. This is what we have done, for example, very early on in the COVID pandemic. A huge number of tests became available, commercially available tests for the detection of just SARS-CoV-2. We compared and evaluated 13 of these tests, and most of them performed very well, with PCR efficiencies of over 90%. One assay performed a little bit less, with a PCR efficiency of only 80%. So it's very important to do these validations. This is, for example, a validation of a number of multiplex tests or multiplex panels. This is a recent study in 2022, evaluating and comparing the BioPharm film array test targeting more than 18 viruses, and atypical bacteria, the Luminex, as already mentioned, targeting 19 viruses, only viruses, but also the research use only TaqPath array card, also targeting a number of viruses and atypical bacteria. And in this evaluation, the overall virus detection was very high. For each of these three assays, very high, above 95%, almost 98% for the film array, 96% for the research use only part, and 94% for the Luminex test. So the overall performance of these three assays was very high. Nevertheless, there are a number of differences between the detection of different viruses. For example, for influenza A, the positive percentage agreements was 100% both for film array and for Luminex. It was 95% for the array. Whereas when looking at specifically coronaviruses, the positive percent agreement was 90% for film array, but only almost 82% for the Luminex assay. And for para-influenza, it was 84% for the TaqPath card. So the sensitivity and also the specificity may differ for different viruses. So it's very important, depending on the objectives of what you're going to study, to do these validations and to test or to choose the test that fits more your purposes of the study. That's also what we did when we started a second large European study. We evaluated the research use only TaqPath array, custom-made array, and we compared it and validated it against the fast-track assay. We used, to do this validation, external quality assessment panels from QCND, but we also used archived nasopharyngeal swab samples, positive for SARS-CoV-2, but also positive for a range of other viruses. And what we could conclude from this evaluation is that the research use only array performed very well and had a sensitivity of 100%, not only for SARS-CoV-2, detecting here 19, whereas only 16 for the fast track, but also for the other viruses, higher numbers, such, for example, for RSV and for especially for rhinovirus, but also for para-influenza viruses, higher numbers were detected with this array compared to the fast track. So that's why we choose for this assay for a further European study. Let's move now to the real subject. What is the importance of respiratory viruses and the importance of bacteria in lower tract respiratory infections in patients consulting in primary care? And I would like to discuss this firstly based on a large study we did and we published in 2018. This was the first large European prospective case control study, including standardized sampling material, but also a comprehensive panel of molecular and non-molecular diagnostic tests to have an estimate on the real importance of the different viruses and the real bacteria. This was the GRACE study, and GRACE stands for Genomics to Combat Resistance Against Community-Acquired LRTI in Europe. So it concentrates in our part on the etiology of LRTI in Europe. It was an EU-funded study by the 6th Framework Network of Excellence with the overall aim to combat antibiotic resistance. The study was performed in 16 primary care networks in 12 countries from north to south and from east to west. And in total, more than 3,000 patients were included with LRTI, but next to these 3,000 patients, also almost 2,000 controls were included. And this was the very first very large study, including also a number of controls, and I will explain you later why these controls are very important in such an etiologic study. From each of these patients and controls, a number of samples were taken. So Symptomatic patients were assessed at the first day. The GPs recruiting these patients, they received a set of standardized sampling material, but they also received detailed instructions on how to sample these patients. So within 24 hours after admission and inclusion in the study, the patient was sampled for serum, for sputum if available, because not LRTI have sputum production, but also 2 nasopharyngeal swabs, one for viral analysis and one for bacterial analysis. The same patients were seen 3 weeks later, in between day 28 and day 35, and they were again sampled for a blood sample in order to do serological analysis, but also the 2 nasopharyngeal swabs for bacterial and viral analysis. And the controls were sampled again only for the nasopharyngeal swabs. All these samples were labeled, they were stored in local labs, frozen, until they were transported to the central lab, our lab in Antwerp, for the analysis of all these samples. And from almost 99% of all these patients, both these nasopharyngeal swabs were available, which is of course very important to do such an etiologic study and not to be biased by a number of patients who wouldn't allow to sample them. Now, how did we do this study? The analysis was done, as already mentioned, in our lab in Antwerp. The nasopharyngeal swabs in universal transport media were analyzed for the presence of all the respiratory viruses with PCR-based methods, but also with the atypical bacteria, because we know that Mycoplasma, Chlamydia, Bordetella are difficult to grow. But we also had a nasopharyngeal swab in skimmed milk for the culture of Strep pneumoniae and Haemophilus influenzae. Why did we culture for these typical bacterial pathogens? Because it's very difficult with a PCR-based test to make a distinction between colonization and infection for these pathogens. Many patients are colonized not only with Haemophilus influenzae, but also with Strep pneumoniae. And so it's very difficult to make a distinction between a patient who is colonized and a patient who is really infected, which is still more easy to do that with culture techniques. We also used serology for the atypical bacteria because we know that that increases the sensitivity. Now, let's concentrate on the results and let's first discuss the bacterial infections. As you can see here, we split up the results for the whole group of lower respiratory tract infections, the more than 3,100 patients, and the specific group who presented with a community-acquired pneumonia. When we look at the percentages of Strep pneumoniae and Haemophilus influenzae, they are relatively uncommon in the whole group of lower respiratory tract infections, around 5% only. But they are significantly more prevalent and more important in the CAP group of patients, almost 10% of Strep pneumoniae, 14% of Haemophilus influenzae. In total, when looking just at bacterial infections, in 21.3% of these outpatients, a bacterial etiology was detected. So in 1 out of 5 patients, these patients present with a bacterial etiology. Now, what about the viruses? And this looks like a complicated table, but I will guide you through it. Let's just concentrate in this slide on the first column and on the last column. The first column presenting the results of the patients with symptoms, the last presenting the results of the controls, and these controls were matched for age and for gender, but also matched in time. They had to be included within the same 2 weeks period as the cases. And that's very logical because, as we will see later, there is a high seasonality of many viruses. So some viruses present in very specific peak periods during the winter. So it makes no sense to include a control of an influenza patient 3 weeks or 4 weeks after the influenza patient has been included. What can we conclude from this slide? In total, in more than 50% of these outpatients, an etiology was detected. But does this also really mean something? The most important viruses were the rhinoviruses, with almost 20% of patients presenting with a rhinovirus, almost 10% with an influenza virus, but also the seasonal coronaviruses were quite important, 7.4% in this case. When looking at the controls, these viruses, such as influenza, was hardly detected in controls, also coronaviruses, but also very low rates of rhinovirus in these control patients. In any case, there was a highly significant difference between the cases and the controls, meaning that these viruses are really the causative agents and are not really innocent bystanders. They are the cause of the respiratory infection. But it is also the case, and this was much less known, for less important viruses or less prevalent viruses, such as RSV, almost 5% in the cases, only 0.5% in the controls, human metapneumovirus, also more than 4%, and hardly any control with a metapneumovirus. Parainfluenza virus, also a significant difference. So this means that all these viruses are really causative viruses and are indeed the cause of the lower respiratory tract infection for which the patient consults with their physician. That is not the case for these viruses, such as polyoma, and I indicated this one because this was the most prevalent. They are not very prevalent, but this was the most prevalent one, with 1.4% in the cases, but even 1.7% in the controls. And that was also the case for the other polyoma virus. For the BOCA viruses, same rates in cases as in controls, but also for human adenovirus in this study, same percentages in cases as in controls. Meaning that these viruses probably are not the cause of the infection for which the patient consults, but are rather innocent bystanders. And that's also what we can conclude when we look at, again, the first column of the table with the cases, with the cases seen after 3 weeks, after 28 or 35 days. These are the follow-up samples. Again, when we look at the important viruses, influenza, nothing anymore in a follow-up sample. Same for parainfluenza virus, but also for the other respiratory viruses, very low rates of positivity in follow-up samples, meaning that persistence of viral RNA is very uncommon for these important influenza, rhinoviruses, RSV, metapneumovirus, and human coronaviruses. Whereas, again, this is not the case for the other viruses, adenoviruses, polyomaviruses, and BOCA viruses. So, again, there is no significant evidence for a causative role of these viruses. These are probably mainly innocent bystanders. What about dual infections or combined infections? And I made a distinction here between the whole group of lower respiratory tract infections and the group presenting with community-acquired pneumonia. What is clear from this figure is that bacterial infections are more prevalent or more important in the CAP group compared to the whole group. 23% solely bacterial infections compared to only 11% in the whole group of LRTI. Many infections are dual infections, both dual bacterial infections or combinations of bacterial and viral infections, But main conclusion for bacterial infections that they are much more important in CAP group than in the LRTI group. When concentrating on the viral infections, more viral infections in the LRTI group compared to the CAP group. And when we concentrate, and that's not shown in this slide, but when we concentrate on the viruses that we consider as causative, as significant, so for example, influenza, RSV, but also metapneumovirus, parainfluenza viruses, these mainly occur as single infections. So that means if a patient presents with an influenza infection or with an RSV infection, mostly no other pathogen is detected. Single infections. Whereas for those viruses that we consider as innocent bystanders, we do not detect them as single infections, but mostly as dual infections, confirming again that these viruses, and then I talk about the polyoma viruses, the Boca virus, the adenovirus, they are mainly innocent bystanders being detected with another virus or another bacteria that are the causative viruses. Very important is also to see at or to look at the prevalence of the different viruses in view of the age groups of the patients. And that's clear from this table where I split up the age groups in younger patients below the age of 25 years of age, adults in between 25 and 65 years of age, and the elderly over 65 years of age. What's important here? When looking at influenza, then maybe strikingly, but understandably, the prevalence of influenza virus in the age group of 65 and older is much lower and significantly lower, higher, significantly lower compared to the younger age groups. And that is understandable because probably in this age group vaccination is much more important compared to vaccination in the younger age groups. That's also in most of the guidelines, influenza vaccination in elderly over 65 years of age. What is also important in this table, when looking at the rhinoviruses, that's the other way around. Rhinoviruses are much less prevalent in 65 plus compared to the younger patient groups. And that's also significantly different. And that's also understandable because this age group may have had rhinovirus infections many more times before their current age, so they may have built up a certain immunity against a number of rhinovirus variants, because you know rhinoviruses have many variants. Younger age groups have not been in contact with all these variants so often, so the chances of having higher prevalences in these age groups is much higher compared to the older patients. And the third important conclusion is concerning the RSV infections, where these are much more prevalent in the 65 plus compared to the younger adults. And RSV is very well known as a very important virus in the newborns. That was very well known also in the beginning of the GRAY study, but it was not so well known yet at that time that also 65 plus are a risk group for an RSV infection. And that has been demonstrated very well in this study. There were no significant differences for the other respiratory viruses, but this finding gains more and more importance. And that is also very nicely shown in a recent study where the morbidity and the mortality was looked at specifically for RSV virus in an older patient group, but this time in a hospitalized patient group, not in a community patient group. These authors studied more than 600 RSV cases compared to almost 1,900 influenza-infected hospitalized patients. And what they could conclude is that the RSV patients generally were older than the influenza patients, but RSV infection was also associated with a greater odds of a longer length of stay in the hospital, with pneumonia and with intensive care unit admission. And what they also could conclude is that the mortality in this RSV group within 1 year was higher in the RSV group compared to the influenza group. So RSV may result in a higher morbidity, but also in a higher mortality among older hospitalized adults. And that's very important. We need to recognize RSV much more and the importance of RSV in this age group in order to evaluate new antivirals and new RSV vaccines for this age group. What about the other spectrum of life in the very young? And in this study, it's also a very recent study. In this study, the authors looked at the prevalences of the different viruses in the very young children compared to older children. Babies below the age of 12 months, in between 12 and 36 months, and above 36 months. They looked at the different viruses, but also at the seasonality. And what they could conclude, and that is well known, is that RSV is indeed very important in babies, 30% in the below 12 months of age, 17% still in 12 between 36 months of age, and only half of these prevalences in older children. There were no significant differences, for example, for influenza, for parainfluenza virus or metapneumoviruses being as prevalent in all these age groups. What about seasonality? As explained earlier, also in this study, RSV and influenza were most prevalent during the typical winter months, in between January and March being prevalent in 28% of the cases and in almost 12% of the cases respectively for RSV and for influenza. Whereas influenza, for example, was much less prevalent before in autumn and after in spring in this study. And that's the same finding as also in our study. Whereas parainfluenza is more prevalent in autumn and in spring compared to the typical winter season. So RSV was the dominant respiratory pathogen in preschool children. That's also what we know. And both RSV and influenza are highly seasonal. That was also the conclusion in our study and in other studies. What we also could conclude from this study is that there is a high colonization rate of Streptococcus pneumoniae in these children. More than 40%, sometimes even more than 50%. And this has to do, of course, with the fact that these children are closely together either in daycare centers or in kindergartens where they play with each other, cough into each other, and where colonization rates are very high in these children in infancy. The next study we performed is also an EU-funded study in the 7th framework, and that was the RECOVER study, and that was during the COVID pandemic. This is also a study in primary care, the SOS COVID study, which was an observational study of community-acquired respiratory tract infections during a time of widespread COVID in primary care. And in this study, the aim was to describe not only the etiology, but also to look again at the clinical management and the outcome of primary care, of patients in primary care across Europe. 9 countries were included in this study. The results of this study are submitted for publication. It was again a study in primary care. Again, all the physicians had the material, the standardized material to take nasopharyngeal swabs in universal transport medium, and to be analyzed for this study more than 850 nasopharyngeal swabs. What you can see here is again the prevalences of the different viruses. What is very striking, no influenza at all during this COVID pandemic, no RSV at all during this COVID pandemic, but mainly, as also expected, large prevalences of SARS-CoV-2. This is in outpatients. It was even higher in hospitalized patients. And the only other important virus that we detected was rhinovirus, almost 16%, a little bit of seasonal coronaviruses and of human metapneumovirus. But very strikingly, no influenza, no RSV peak during the COVID pandemic. There were large differences in the prevalences of the different viruses, both for rhinovirus as for SARS coronavirus, and the SARS coronavirus prevalence ranged from 7 to 52%, overall almost 23%, but with large differences between the different countries. For example, in Ireland and Belgium, prevalences of lower than 10% compared to Spain, more than 30%, Hungary, 35%, Moldova even 52%. And this, of course, has everything to do with the timing of the including of the patients into the study, the timing of the sampling, but also maybe to the inclusion criteria of the patients. As we can conclude again from both studies, the Gray study and the COVID study, large differences, influenza being responsible for almost 10% of infections in the Gray study compared to no influenza at all in the COVID study, 5% of infections in the Gray study, no RSV at all in the COVID study. And that was also what was concluded in, again, a very nice and very recent study in 2023 from June and colleagues, where specifically RSV was investigated in older adults before and during the COVID pandemic. In this case, more than 2,300 patients were included. The pre-pandemic attack rate was 2.5%. As in our study, no RSV positive cases were seen during the COVID pandemic, and even not during the RSV season within this COVID pandemic, and the attack rate increased again in summer of 2021 after the first wave of the corona peak. So in this cohort study, the burden of RSV positive acute respiratory in older adults during the pre-COVID was substantial. It was reduced to 0 during the COVID pandemic, but raised again in summer 2021 after the COVID pandemic. So in general, what have we learned? What can we conclude from lower respiratory tract infections in patients consulting outside the hospital in primary care? In more than 50% of adult outpatients presenting with LRTI, a viral etiology can generally be detected. Only in 1 out of 5 patients, there's really a bacterial etiology detected. So respiratory viruses are very important. They are the predominant causes of LRTI. Human rhinovirus is the most important of all these viruses, but also influenza and coronavirus, of course. But next to these known and important viruses, also RSV and metapneumovirus may play an important role, and RSV mainly in older adults. So we can conclude that if you go to a doctor in the winter season or even outside the winter season with a lower respiratory tract infection, the doctor may conclude that you have a virus, and to the next patient you have a virus, and so on. So I would like to conclude with the words of Paul Liddle, who has concluded from this Gray study that there are convincing data that should encourage physicians now in primary care to refrain from antibiotic treatment in low-risk patients in whom pneumonia is not suspected. Thank you very much for your attention, and that's what I would like to end with.
Hey everybody, my name is Israel Figueroa. I'm a senior product manager here at Thermo Fisher, and I'm excited to talk to you today about some of the CIVD solutions we have available for respiratory tract infections. I think we just learned a lot about why it's important to know the etiology and really identify the pathogens and how that drives some treatment decisions. So looking forward to sharing more with you today. So, what is the value of molecular testing, specifically around PCR? So really can aid in diagnosis and management of inpatient and outpatients. So helping, manage cohorts within a hospital, also manage treatment decisions. And specifically why qPCR versus some other technologies. So it's really fairly for accuracy and faster time to results. So things like culture, some viruses are just very difficult to culture. Some of the atypical pneumonia pathogens are very difficult to culture. And some of the bacterial pathogens that are easier to culture, just, the nature of culture requires more time. So PCR can help reduce that turnaround time to help drive those treatment decisions or cohorting decisions. Lastly here, for monitoring a patient's response to treatment, and you can use alongside clinical presentation, you can be using PCR results to help drive and make those decisions. So wanted to cover at a high level what's in our Thermo Fisher portfolio for respiratory IVD solutions. So you can see here a variety of viruses, including SARS-CoV-2, which we've been a big player in the outbreak response. Some bacterial targets, including some atypical pneumonia targets, and lastly, fungal target and Aspergillus, which is kind of a unique offering that we have here for immunocompromised patients. So these groups are kind of split up into two, and I'll speak to them a bit separately because they're in slightly different families. This gives you a high-level overview of what we offer. So I'll start with the first family here is TaqPath Respiratory Solutions. So, on the left here is our COVID-only solution. This has been, very instrumental in the pandemic response over the last few years throughout the world, but played a big role in Europe also. I think one of its strong points is this built-in redundancy of 3 targets. So there's 3 different COVID targets on 3 separate optical channels. So that really helps against emerging variants that might elude detection. So having that redundancy gives you a lot of confidence in the results. And I'll go into a little bit more detail later, but wide compatibility with different PCR instruments that large install bases that may already be in your labs today. In the middle here is our winter panel, is what a lot of folks call it. So in addition to COVID-19, SARS-CoV-2, there's a detection of influenza A and B, undifferentiated on the same channel, and RSV. So within a single reaction, single multiplex reaction, you'll be able to detect all 3 different pathogen groups. And one thing of note here is really we've shown great performance in the case of co-infections. That if you have a very high titer COVID patient, that high titer COVID won't mask, for example, a lower RSV or influenza viral load. So we've shown good co-infection performance there. And on the right, we have our viral select panel. This is our newest panel, kind of continuing the theme of multiplexed viral respiratory panels. This one includes here adenovirus on one channel, human metapneumovirus, rhino and enterovirus. These are together on the same channel, undifferentiated. And similarly, parainfluenza 1, 2, 3, and 4 on the same channel, undifferentiated. So this is kind of an extension of the COVID flu for certain scenarios where you want to get deeper viral pathogen coverage. So as I mentioned before, I think these kits have been validated across a wide variety of qPCR instruments. The exact instruments vary a bit by product, but I just want to give you a sampling of some of the instruments that are included. So here in the QuantStudio 5 family, you'll see both 96 and 384 wells, depending on what's the throughput needs and different reaction volumes. 7500 system is still a workhorse and with a large install base. So that's been validated. And here, once again, the QuantStudio 7 Flex for folks that need that higher throughput with a 384 well block. So just kind of want to illustrate that there is a wide instrument coverage here. For the kind of overall workflow for this family of products, receive samples, often starting with a nasopharyngeal swab. Sample extraction is happening with a Kingfisher Flex, and that's what's been validated across these different solutions. And those of you that are not familiar with the Kingfisher Flex, it's a great instrument. It's able to process all 96 samples on a plate at the same time. So really high throughput, and also very fast because it's processing everything in parallel. And that's being used alongside the MAX viral pathogen 2 extraction chemistry. So after extraction, you'd set up your PCR run. We kind of already covered that there's a wide variety of instruments, across the portfolio that have been validated. And then it comes to the results, and these will all be running on the pathogen interpretive software. So this is going to be automating the results interpretation and can do data reporting out, but across all the different solutions in this product family. So next, I want to cover the other family, which is the recent addition here to the GeneProof respiratory tract infection assays. So some of the highlights for this product family here. Quickly and affordably expand the menu offering using a lot of the same instrumentation that you might already have in your lab. I think the most interesting thing about this product family is the testing for the right targets at the right time. So you'll see it's a fairly large collection of pathogen assays, but depending on your lab, your patient population, regional needs, you can mix and match different pathogen or different assays to really build a panel that meets your needs. Often, there's large syndromic panels out there, but maybe a certain percentage of the pathogens on the panel you don't your patient population doesn't apply to, or doesn't regionally matter. So this really helps you pick exactly what you need and build a panel yourself. And then that just drives some more efficiency, not querying for pathogens that are not relevant. And you also see there's some workflow efficiencies across the different kits. So I'll just do a quick highlight of the kits, and I'll call out some things that are of note. So enterovirus, so the viral select panel includes enterovirus detection alongside rhinovirus, but if you need specifically enterovirus differentiation, you can run this panel or run it as a reflex test to the viral select panel. You'll note here, this one has no cross-reactivity with rhinovirus. The adenovirus kit is interesting in the sense that it's suitable for both respiratory and gastrointestinal, so you kind of get a 2-for-1 test here. You'll see that in the sample types, swab is validated, but also stool is validated. So if your lab is doing gastrointestinal testing, this kit can help be dual purpose. The mycoplasma pneumonia kit, going into more of the lower respiratory bacterial pathogens, and you can see that in the sample types listed, BAL and sputum. I spoke briefly about the Aspergillus kit. This is a fungal target that's important for immunocompromised patients as a risk, and it really enables targeted antifungal therapy for resistant aspergillosis. On the right here, continuing with those atypical bacterial pneumonia pathogens, is chlamydia pneumoniae with, once again, lower respiratory sample type claims. And then lastly, we have a Bordetella differentiation kit. So this kit detects both Bordetella pertussis and parapertussis in a single reaction as a multiplex, but it does distinguish, so you will be able to differentiate between the two. In the middle here, we have the Mycobacterium tuberculosis kit covering the tuberculosis complex. You'll see, fairly large set of species within that complex. So I think what's noted here on the bottom is that these can be combined. So you can combine them to kind of build your own panel depending on what your lab needs. And there's a lot of workflow synergies amongst these in terms of shared extraction possibilities and shared thermocycling possibilities. A little bit on that. So the workflow here is receive samples. I've already spoken to that in the previous slides. What's been validated across the specific kits. Sample preparation here is a bit more open than the previous family we discussed. It's kind of according to the IFU, and it's fairly open as long as you're using something that's been validated for the claimed sample type. PCR instruments, this one will vary by kit. So that'll be indicated in the instructions for use. And then analyzing and reporting, once again, will be based on what's recommended in instructions for use. So we've really talked about one section here. We're really specifically talking about respiratory tract infections today. So we covered what's on the left here, but you'll see within the portfolio, it's fairly large. So there's transplant, a wide selection of transplant targets, sexually transmitted infection targets, bloodborne, thrombotic mutations, and vector-borne, and all of these have similar design and workflow. So it'll help with implementation and training within your labs and operations. And to that effect, there is a universal internal control that can be used across these different kits that will just really designed to help improve and simplify operations. So yeah, that's our kind of offering right now within the respiratory diagnostic space. But thanks so much for the time, and I'll pass it on. Thanks so much, and looking forward to the questions.
Thank you so much to both of our speakers for these very informative presentations. And we will now start the question and answer portion of the webinar. So if you have a question that you would like to ask, please do so now, and we'll answer as many of the questions that we have time for. Let's start. So the first question we have is, Professor Ieven, you mentioned that you used a qPCR approach for detection of viruses and atypical bacteria and some other methods for other bacteria in your study. So can you maybe tell us a little bit more why qPCR is a method of choice for these bacteria? I believe you mentioned Mycoplasma, Chlamydia pneumoniae, and Bordetella, or if any other. Thank you.
Yes, of course. Well, Mycoplasma, Chlamydia, and Bordetella are bacteria that are very difficult to culture, first of all. And if they are cultured, they can be cultured, but the time to positivity is also, for some of these, very long. For Mycoplasma, it may take days to weeks. For Chlamydia, even longer. And for Bordetella, it's also not very easy to culture it. In addition, these bacteria, when they are found, they usually, and that has been shown in many studies, they usually are also causative pathogens. So if we find Mycoplasma, it is the cause of the infection. The same for Bordetella. So there, a yes or no answer by PCR is very rapid, is sensitive, and is the method of choice to detect these pathogens. In contrast to the more conventional bacterial pathogens such as strep pneumonia and Haemophilus influenzae, we can of course detect them by PCR very rapidly, very sensitively, but maybe PCR here is a bit too sensitive, meaning that we also will detect colonization, and colonization is present in almost everyone, and certainly in children. And we tried in several studies to make a distinction between colonization and infection by PCR based on the CT values. and on the bacterial loads. And we could conclude that a bacterial load of 10 to the 4th bacteria CFU per ml might be a cutoff, but the range is too high and there's too much overlap between the cases and the controls to really be able to distinguish. You can use it, of course, but it's much more difficult than for viruses and for atypical bacteria to really decide on the cause of the infection.
Yeah, thank you for that. There is another question actually related to that regarding when you presented your study and explained how some viruses you consider just colonizers, and the question here is to determine this colonizer, was it related also to the high CT value that you detected, or simply a positive negative?
Simply positive negative. So for all these viruses, we do have the CT values, but the results I presented are just based on a positive negative answer. So for the Boca virus, the polyoma viruses, adenoviruses, they were present both in cases as in controls, and based on that we concluded that there's no significant difference, so these are probably colonizers or innocent bystanders.
Thank you so much. One question for Israel. Is Quantius Studio 5 a validated instrument for the TaqPath menu GeneProof tests, and can other instruments from other manufacturers for extraction of qPCR also be used according to the IFU?
Yeah, so Quantius Studio 5 is validated pretty much across everything that I spoke about, all those kits. In terms of the extraction, it depends. The GeneProof family of assay kits it's pretty open as to what you can use for the COVID and the multiplexes, the respiratory virus multiplexes. Those are the claims do specify the Kingfisher extraction system. So those are somewhat specific, but a lab can always do their own validation if there's a different preferred extraction method, depending on local regulations.
Thank you. Another question for Professor Ieven. So you have shown a lot of data today, mainly on patients in primary care. Do you think that similar etiology would be also observed in hospitalized patients, or do you think there would be some differences?
Well, it depends. Well, patients admitted in a pneumology unit coming from outside of the hospital, these are mainly then community-acquired pneumonias or community-acquired lower respiratory tract infections, and mainly the same pathogens will be important to be detected. On the other hand, when you concentrate on patients who are admitted already for a long time in the hospital, then hospital-acquired infections may be important, hospital-acquired lower respiratory tract infections also. And for example, in ICU units, then other pathogens have to be taken into account as well, such as gram-negatives, gram-negative bacteria, but also Legionella, although Legionella is a community acquired, but it depends on whether you concentrate on hospital acquired infections, ventilated patients with hospital acquired infections, or just LRTI coming from the community and patients being hospitalized. In the latter, it's the same pathogens. In the first ones, mainly in patients admitted at ICU, you have to use a broader panel and for example, also include Candida infections, Aspergillus infections, and certainly also gram-negative infections.
Okay. Well, thank you again, Professor Ieven and Mr. Figueroa, for your time today and these important insights. I apologize, but we are at time, so we need to wrap up. We would also like to thank Labroots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before you go, I'd like to thank the audience for joining us today and their interesting questions. Those questions that we did not manage to answer and those submitted during the on-demand period will be addressed by the speakers via the contact information you provided when you registered. The webinar can also be viewed on demand, and Labroots will alert you via email when it is available for replay, and we encourage you to share that email with your colleagues who might have missed today's live event. Until next time, thank you very much and goodbye.
Thank you. Bye-bye.